mental health care was being created, when therapy was first being sort of something that was offered, it wasn't intended to be something for everybody. It was intended to be something for a select group of people who could access it, or for people who were institutionalized. There was nothing or no assumed need for most of the population. And that's where our system has grown from. And now we're stuck in this situation where I study young people. 80% of children and adolescents with a significant mental health need access no treatment at all.
So, Jessica, this lab, the idea of population health not being able to have access to, I guess you call it multiple visits for psychiatry. Has this idea been around a long time? Is it a recent kind of idea?
It's been around in terms of the idea of offering somebody support in a single session due to these access barriers. It's been around for way longer than most people realize, including most professionals in my own field, clinical psychology. The first documented single session intervention was done in the early 20th century. Back then, it was totally absurd to think that somebody could get better with anything but long-term psychoanalysis. But it was written about in a book of, maybe we should consider the idea that we can help people in a single assessment with some kind of reliability. And the research really started in the 80s or the 90s. And in the past 10 years or so, it's taken off quite a bit. But unfortunately, the issue of access and lack of that is just getting worse, not better every year. So it's something that's becoming more and more important, I think, for people to reckon with.
That early intervention, can you just cite briefly what it was? Was it a piece of advice? Like, what was it? What can one session, one messaging, how could that help?
Absolutely. So that initial session that happened originally, the gist of that was helping people understand that to get this far in life, you have to have developed some coping skills. You have to have figured out some stuff along the way to get to where we are right now sitting here. So let's figure out how we can harness your strengths that you have to have if you've gotten this far in life in an intentional way to take the best next step for yourself. And that opens doors for people. That's the basic emphasis of solution-focused therapy, of assuming strength rather than deficit, which is what a lot of treatment does. It assumes people lack skills or abilities or knowledge even, and opening the door for them to be able to draw from within to make changes in their life. And for this book that I wrote recently, I talked to 98 people about what they experienced as turning points in their mental health recovery trajectories, because I was really curious, like this idea of a moment mattering, of a brief experience or intervention making a difference, seems to resonate with a lot of people who struggle with mental health problems. But I would really wanted to hear more about what people thought made those moments matter.
Did you come to some universal truths, in interviewing 100 people?
Yeah. So universals is a big word. I'm a scientist, so I hesitate to say anything is a universal truth, although I guess that depends on the kind of science you do. But in my world, I did these interviews because I wanted to get lived experience narratives into the research puzzle because they were really lacking. And I was able to extract overall themes based on what people shared with me that kind of undergirded a lot of what the turning points were for people. And that was, one, moments where people surprised themselves, moments where people suddenly found themselves doing or taking a step that they never imagined would be possible for them. And really being present in that moment and observing power they didn't know that they had or strength they didn't know that they had. Another one was feeling seen by others, feeling understood, validated, appreciated in a way that they hadn't before. That can be identifying for the first time a diagnosis that explains a lot of what you've been going through, or somebody recognizing something about your experience that you hadn't before, but it really resonates in that moment. Another is reclaiming your narrative, kind of realizing the future that you actually want for yourself and taking that first step towards making that future happen for you. Another one is giving back, actually. So a lot of people got better by helping others. And when they first experienced that, I think that inner joy and validation and satisfaction of being able to use your struggle to support somebody else going through something.
So, when I think about therapy, just from my own personal experience, it's like been with the same person a very, very long time. Each insight I might get could take years to come up
Yeah.
with something meaningful. And usually my therapist is just listening to me, prattle on. In this situation, if you're just going to see somebody one time, where do you begin? Does this mean that you have an idea already about where you're going before you start? How do you do this? I'm assuming a session is an hour or 50 minutes.
It can be, but it doesn't have to be. So when I talk about single session interventions, I mean any interaction with a provider, a program, or even a self-help tool that isn't expecting you to come back. So that assumption that everybody is going to be able to return for session 2, which as it turns out, really isn't true. The most common number of interactions folks have with any kind of digital or in-person mental health service is 1. That's what makes a single session intervention, not a specific length, not a specific theoretical orientation. So there's like cognitive behavioral therapy, psychoanalysis. That's not what I mean. I mean, the intention is there that if you need more, great, that's okay. You can pursue more in the future, but we're going to make the most of this time that we have right in front of us, because that's all we know that we're going to get.
We're doing some work for the state of California and around this. They're launching a new wellness coach. And so everything that you're talking about is so relevant, because this idea of it could be just, you said to Jesse, just seeing who you are for where you are in that moment. But we also know we have a shortage of any kind of healthcare workers anyway. We have stigmas. People are afraid, or in different languages, for example, in different cultures, the idea of going to get help or traditional psychiatry or therapy is not as acceptable. So is this just a broadening? It's finding also the wellness in people. Is that correct? Finding what, like you said, what's strong in a person.
Yes, strength-based approach, 100%. I see single session interventions as an untapped, largely, opportunity to expand the mental health ecosystem, to bridge gaps in those ecosystems that traditional therapies were never supposed to. They weren't built to. Mental health care was being created when therapy was first being sort of something that was offered. It wasn't intended to be something for everybody. It was intended to be something for a select group of people who could access it, or for people who were institutionalized. There was nothing or no assumed need for most of the population. And that's where our system has grown from. And now we're stuck in this situation where I study young people. 80% of children and adolescents with a significant mental health need access no treatment at all. That's a combination of the provider shortages that you're talking about, but also the fact that the treatments that we've studied and developed are designed to be way longer than people access treatment for in the real world. So I'm really excited about these brief, scalable opportunities to basically give folks who are falling through the cracks of these systems something, and something evidence-based and helpful, when they would otherwise definitely get nothing.
We met you through Noah Robinson. He recommended you. And so the inner world, model. So you're doing a lot of work online as well with Coco and social media. Can you just explain kind of where you're going with all of this?
Absolutely. And I'm a big fan of Noah's work. I think what he's doing is a really important step towards expanding mental health support in ways that are sustainable and appealing to people who are seeking help online. So in graduate school, I got my clinical psych PhD at Harvard. I graduated in 2018. I was trained to be a traditional cognitive behavioral therapist, but I got very frustrated when I saw that the therapy that I was trained to deliver didn't seem to fit any of the settings where kids were and kids were able to access care. I started wondering pretty early on, what can you do in the first session to even make a dent in these problems? As it turned out, as we just talked about, a lot of people had asked that before I got there. And I started really dedicating my time to studying the science of single session approaches, not just provider delivered, but also self-guided interventions. Because a lot of teens live online. That's where they go for seeking help. That's where they go for support. So that's where the interventions need to exist. So creating single session activities that are free, anonymous, so teens are comfortable accessing them, and embedded in spaces they already are, so that they don't have to go find them because what kid is calling a clinic to set up an appointment for themselves. That just made so much logical sense to me as somebody who was working with kids every day. So for my dissertation, I developed in collaboration with teenagers, they were very important parts of my team, very good critics, an online program that teaches the basics of brain science, basically arguing that because of how brains work, because of neuroplasticity, you're born for the potential for change. You're actually built for change.
Right.
That's what your brain is literally designed to do, especially at your age. So these things you're experiencing, things like depression, like anxiety, that feel permanent, that feel like they are a part of you forever, that's just not scientifically true. It can't be. Simply because you have a brain like any other person in the world. And this program, which is called Project Personality, which we've tested now in thousands, tens of thousands of teens across the country, it included narratives of other kids who'd gone through depression or anxiety and recovered through various supports in their lives and effort. We found that it reduces depression even 9 months later compared to active controls. So compared to giving them sort of an online activity that seems interesting and nice, but doesn't really teach a skill.
How do you test this? Is it anecdotal questionnaires? Like, how do you know whether it's made a difference?
Great question. There are validated clinical tools that have been studied, developed over years and years by clinical psychologists, such as the Children's Depression Inventory, the Patient Health Questionnaire, that we know can reliably detect change in response to treatments when people fill them out. So they're questionnaires, but they're not questions I made up. They're questions that are used across all clinical trials for depression. And we can look at whether symptoms, as rated by teens, go down on that validated questionnaire from before they take the intervention to 3, 6, 9 months down the line. And we also, because we know self-reporting bias is real, in our first study of this, we also asked parents, did they get better? So it wasn't just the kids self-reporting, yes, I feel better. It was also their parents observing, wow, they seem better. And because we got agreement across kids and parents, and because we've now done 3 more randomized controlled trials with several thousand kids with this intervention over the course of the last 5 years, we trust it. And that led to our work with organizations like COCO. Because if we have these self-guided tools that anybody can access from anywhere at any time, why not embed them into the online spaces where teens already are to make those spaces potentially helpful rather than, as many are worried, they might harm folks, right? So COCO is a digital mental health nonprofit directed by Rob Morris, who is fantastic. They partner with social media platforms and digital online platforms to embed mostly peer-to-peer supports, mental health self-guided tools directly into those platforms. So you don't have to download a new app. You don't have to go anywhere you wouldn't normally. The support comes to you based on what you search for. For instance, if you search for suicide or depression, a resource pops up exactly based on what you just searched for. We decided that it made a lot of sense to try embedding our interventions into COCO's resources so that people would just be offered a single session intervention at moments of need based on their activity on Tumblr, for example. We tried this out. We reached 6,100 teenagers within a year of trying this out on Tumblr specifically. And we found that the effects were just the same in that real world application as in our controlled trials that we'd done that were NIH funded, very specific research parameters. Usually when you put things into a real world setting like that, you see what researchers called a voltage drop, as in it doesn't work as well when you don't have all the tightly controlled circumstances that a study does. But we didn't see that. And I think that's because teens helped us make the things, but also because we had this context for delivery in mind from the start of what can we do, assuming that teens may not be able to access anything other than what we can offer right now.
You know, what is an intervention? You know, it's like, is it a session where you sit down with somebody and talk to them? Is it a questionnaire? Like, what is an intervention? And how do you know whether the intervention is really good or whether the whole concept works as an idea?
An intervention, so many researchers would have so many different answers for you for that question. I think of it really broadly. It's an intentionally delivered experience, is what I would say. So that can be delivered by a human or a trained therapist or a peer. It can be something that's self-guided, a program that you go through, like any of the mental health apps that are out today. But the goal of an intervention is to change some kind of behavior or thought or feeling. And that is my biggest picture possible definition, I think. So there are a lot of things that fit into that category.
Have you seen ones that you go, well, this one's more effective than that one? And have you sort of come to some insights about which kind of intervention is meaningful?
Yeah. So in terms of single session interventions or like all interventions?
Single.
Yeah. So when I first got interested in this topic, again, I'm a scientist, so I need to know all the things. So I did a meta-analysis, which basically is a statistical synthesis of every single study that's ever been done on single session interventions for young people. Back in 2017, when I did this study with my graduate advisor, who has spent his entire career on long-term psychotherapy trials.
Mhm.
So he thought I had made a mistake when we saw the results. I
Wait,
didn't.
because he's doing like 25, like Jesse, 50.
Yeah, like 16 to 20 session therapies. And I'm saying that
Mhm.
one can do something. And he's like,
Wow,
I
okay.
think you're wrong.
So is this initial phase a survey
So
of different interventions?
all of these studies, all of these clinical trials that are included in my overall meta-analysis,
Mhm.
they all have a single session intervention that they're testing, some kind of control group that they're testing it against, and they use those validated measures like the ones that I used in the trial I mentioned earlier, Children's Depression Inventory, Patient Health Questionnaire, to track, did people's symptoms of mental health difficulties change from before to after the interventions? And you can statistically combine the results of all 50 trials and look at which ones for which problems for which people are most helpful. And across those 50 trials of single session interventions, we found that the overall effect was not much smaller than the overall effect for 16 session interventions.
Not much more. Okay, that's pretty significant then, yeah.
Yeah, so they were way closer together when we looked at the graphs than I was expecting, and certainly than my advisor was expecting. By the way, he later wrote the preface for the book.
Your book, which I read that introduction.
Yes.
He gave you rave review and glowing.
Yes, he's been very kind. His mind has been changed.
So you take 50 different trials done for different purposes, and then you graft them so that you could look at whether the intervention had meaning over a period of time, and then you synthesize that into one structure to understand what the result was, yeah?
Yeah. So our goals for that project were to figure out, can single session therapies do anything for mental health problems in young people? The answer was yes. Then we wanted to see, okay, what problems are they most helpful for? And what kinds of interventions are best in the wide world of the single session interventions that exist? We found that brief interventions for anxiety, super effective. So you can help people face their fears in a short period of time, to understand, as I mentioned before, that you can surprise yourself and do things and face fears and go through experiences you didn't anticipate you could. That's basically the gist of exposure therapy, which is a really well-known evidence-based treatment for anxiety. Single session interventions, however, didn't differ in how helpful they were for symptom reduction based on whether they were given by a therapist or whether they were online. They didn't differ in their effectiveness based on whether they were 90 minutes or 5. So a lot of these baked in assumptions we have, more is better, for example. Human delivered therapy is always better than something that's self-guided. That just wasn't coming out in the data at all. So that really led us down these paths of, well, what is possible? Can we create a super brief single session digital self-guided thing that can really help people?
Okay, so you've seen these 50 different interventions. Now you sit down and you decide, well, can something like this help? Does it make a difference whether it's 5 minutes or it's 90 minutes? How do you decide about what interventions you're going to test?
Yeah, great question. So I had a couple of priorities here in figuring out where I wanted to focus my research, where I wanted to focus really my whole research lab on, what kind of programs are we going to prioritize? My first priority is we got to prioritize based on pragmatics. We have to focus on things that are going to have any chance at expanding the system that we have currently. So I don't want to be redundant. I don't want to create more interventions that won't be accessible. So creating supports that were either self-guided and digital or delivered by non-professionals was super important to me, because that is an opportunity to expand access to supports. Relying on providers, of which there already aren't enough, is not going to work. So it was clearly digital and peer-to-peer support for me. The second was I care about teenagers, and I needed to learn what teenagers wanted out of their mental health supports. And from a lot of qualitative work, interview-based work that we did with teens early on, and from my own clinical experience as a therapist for teenagers mostly, I know a few things about them. And one of them is that they have a natural and adaptive drive for autonomy and independence and decision-making that the world isn't really structured to give them. They don't get a lot of choice in their real lives. So I wanted these digital single session interventions designed for teens to be empowering experiences, to feel like these are things they can own, they can do on their own, and that their voice, their perspective mattered. So in all of our single session online interventions for teens, we include teens' own stories of recovery. We include opportunities for teens to give anonymous advice to their peers, to use their own experiences to help other people. And we make sure that they can access them with or without parent support. Because upsettingly, in our paper that was just published recently, when we ask teens what gets in the way of accessing mental health support when you need it, about a third say their parents. They can't talk to their parents about mental health needs. Depending on culture, that could be more or less of an issue. They don't want to burden their families with their mental health needs, so they just don't say anything. There are dozens of reasons. So creating interventions that tap into these things and empower teens was really important to me.
How do you meet them? Like, how do you find them where they are? And how do you get through the barrier of taking the first step? So in other words, you're putting things out there that they can find. What is sort of the transmission to get them to click in or to ask for the help or take that first step of whatever that intervention is?
Yeah, you're talking about a field that I love, implementation science, the science of how do we get people to do what we know works, which is a very big question. There are a few paths to this. One, we work with companies or organizations like Coco that offer these interventions at the right moments. So relying less on people finding X, Y, or Z resource independently and more on, oh, you just searched for suicide. Would you like to try something that could help? So bringing these things to people's attention at moments where need and motivation is high, I think is really important. And working with these online systems can really help with that. But we also sometimes use single session interventions as a tool to get people to use other kinds of resources for mental health. So the outcome isn't reducing symptoms, but rather increasing motivation to use existing supports in their ecosystems. Right. So as one example, we worked with Coco to create a 1-minute single session intervention that helps people or nudges people essentially to call crisis resources when they search for suicide or self-harm or things indicating risk on social media platforms. All of these platforms have these automatic pop-ups when you search for these terms, like here's the 988, the hotline for getting help, here's crisis text line. But most people, if you talk to them who've been in a suicidal crisis, navigating online spaces, they don't see those as helpful. They don't use the resources. They see it as a perfunctory thing that this company is legally obligated to do. We wanted to see if we could create a more personalized experience through a 1-minute intervention that might increase people's likelihood of using these crisis resources in moments of need. We included, again, a narrative, opportunity to give people advice, brief scientific explanation of why what we were saying was true, and we doubled uptake of crisis resources just by adding that 1-minute activity from 38 to 78%.
So at first you have an idea of who you want to reach. You narrow it down to teenagers, self-harming or an acute crisis. And then you sort of know what you want to say to them. You have a length or an idea of one session. And you say, well, it can be peer-to-peer interventions, right? So is that they're finding somebody else relating a story about their own life, like saying, hey, this is what I did and this is how it worked? Is that sort of what you were thinking from the beginning?
So the peer-to-peer approach is something that I learned from teenagers really needed to be in there because peers are so salient to adolescents, much more salient than anything adults are going to say to them. And that approach isn't reflected in traditional psychotherapies for young people. It's very individual. It's very top-down, provider to teen, here are skills, let's work on them. But talking to adolescents and learning what motivated them to recover or take steps to help themselves, what led them to feel like they had meaning in their lives and purpose and goals, it always came back to peers. And developmentally, that makes perfect sense, but it's just not how mental health programs have been structured. So it's not something I went in with, but it is something that was really clear needed to be at the center of things once you start talking to teenagers.
Okay, so you have a hypothesis. Now, do you have to go in front of an IRB to get approval, or are you actually, okay, you do. So what are those initial sessions like when you're trying to get this approved? Do they have lots of questions, and are they reluctant at first? Are they thinking, okay, this is great, let's give it a shot? What are they thinking?
I have been on many IRB journeys.
Yeah.
And yeah, they definitely have a lot of questions because a lot about this research is new. Recruiting teenagers on social media platforms is new. Having teenagers self-refer is new into online supports without involving their parents. So the main questions weren't around, what questions are you asking them? They were more about what's the case for not involving parents here? Because the legal default is to require parents to sign a form.
What was the age range then was it 13, 15? How did you determine?
13 and up. And the way we determined that was based on social media platforms' policies of not allowing people under 13 to create accounts. So it's not that I don't believe these could be helpful for younger teens. It's that that's who could access it through the channels that we were considering.
Now, a lot of people can access it, but they're also going to have to get through that consent form, which means before they get to this session, they're going to have to really understand what they're signing up for. How complicated was it doing, and how much modification was required for the consent form, especially if you were going to not involve the parents?
Yeah, so we took a lot of steps to make sure that our consent form that teens signed, or assent form, because that's what it's called for younger than 18s, was super clear, super straightforward, and had a quiz. So we only allowed people to actually do the study if they got the quiz right on comprehension of the assent form that they had just read. So we wanted them to understand, where does their data go? Where it's stored? How is their information shared or not with other people? What kinds of privacy protections are you getting? What are you going to receive if you do this study? What can you expect? So we had a lot of opportunities to check for comprehension, attention, all of that before we would allow teenagers to be in the study.
Do you see this being mostly an online intervention, or do you also see, people being able to use this in places where they just can't get any? So can it be administered like Doctors Without Borders, where it's not necessarily a doctor giving the medicine in another country? Like how do you see the physical world?
100%. So in our lab, we've reached more than 40,000 people with these interventions through social media platforms, but also through wait lists, through pediatric primary care, through school partnerships and community partnerships. There are many places that interventions that are brief and easy to train people to offer can travel. And what we've found, as one example, offering people online single session interventions in pediatric primary care visits right after the doctor screens them for mental health problems, right? That's one of the grants and studies we have going on right now. And we find that doing that can increase the rate of uptake of referrals that doctors give, because your sense of hope is activated by getting something right now, right? You feel like, oh, I just witnessed myself doing something and I feel kind of better after doing it. So maybe I should call this therapist. and see, what's possible for me. In other cases, we've trained bachelor's level folks to offer single session consultations to people on waiting lists for clinics. So people who are trying to access care, but who are stuck in this way overburdened system and can't. So they have to wait 6 months or longer to get treatment. What we've done is we've created this solution-focused consultation program that anybody can be trained to deliver and that can be offered to folks right when they call in to get on a wait list. So they're not just stuck wondering when they're going to get help. And we found that this single session consultation, when delivered even by non-professionals, can increase people's motivation for change, can decrease their sense of hopelessness, and can actually decrease their anxiety and depression symptoms even before they start treatment. So I think there are a lot of different applications, and that's why I get excited about this topic, is because there are so many gaps in mental health systems and outside of mental health systems that I think these are really poised to make a difference.
And we're in such a crisis mode. But Jessica, you had your own experience that you do write about. I mean, you don't have to get into the details if you don't want to, but you had the experience of something, you had a moment where your life turned around. You were in crisis. Is that what led you to try to understand like how this could work in a different way?
So that led me to be convinced that the mental health care system was broken. And that's why I'm doing what I'm doing today. So the experience I talk about in my book is I grew up in New York City, which I say, there are, at least anecdotally, so many therapists in New York City, and everyone has a therapist in New York City. But when I needed one, when I was struggling with a really severe eating disorder when I was 12 years old, we couldn't find anything. The ones we could find didn't take any insurance at all. This was before mental health parity laws, which also didn't really stick, but that's a different story. And residential treatment was outrageously expensive. And I went a really long time with totally insufficient care, where I was pretty much just getting by. I had lots of relapses. And in graduate school, I was still struggling. This started when I was 12. And I ended up self-enrolling in this intensive outpatient program. And during one of the sort of supervised meals, which is typical for eating disorder treatment, or afterwards, one of the other patients there came up to me and asked me why I had tried a specific fear food that day, because I had talked about it previously and she noticed. And I kind of just told her, I'm never going to be ready, I don't think, to do this. So I figured, why not just do it today and deal with it? And she kind of looked at me and she was like, what if that's the whole thing? And I was like, what do you mean? She's just doing it and recognizing that it's never going to be easy and you're never going to want to, and just trying each day to just do that. And that made me really upset, because I was like, no, if that was true, I would have recovered by now. That's too simplified and all these things. But she was right. And that stuck with me so much. And I paid no attention to the actual therapy sessions I was in after that supervised meal at all. And that one statement, even though it wasn't planned, it wasn't delivered by a therapist, that really clicked with me and allowed me to see what I could do in a different way than I had before. I didn't realize it at the time, like, oh, I'm going to study single session interventions now because that makes perfect sense. But once I got interested in single session approaches from my own clinical experience as a provider, as a therapist, and seeing the problems in the system and how these moments could be helpful for people in that regard, everything kind of clicked together. And I really knew that I had to figure out how far this could go.
Now, do you still see patients?
I don't see patients today. I am a full-time lab director, professor, and that is many jobs in itself. For the past 5 years, I have been supervising students who are learning to be therapists and giving them feedback on that approach.
And what are your thoughts about your students? If they're selecting to come into the lab, this idea has taken them a bit, are they excited about it? And what do you see? Are they bringing it to a different place?
The students are taking it to so many incredible places. I can give some examples. So the work with Coco was a total collaboration with my students, Mallory Tobias and Katie Cohen. We all worked together to figure out how can we creatively leverage the evidence-based digital tools that we've developed and reformulate them for this big dissemination context. So that was very much a collaborative effort. My student, Jenna Sung, has been really interested in supporting parents through single session approaches. And she took the lead on designing a one-session digital program for parents of young kids to prevent anxiety, basically by teaching parents that helping their kids face fears and approach challenges rather than rescuing, even though that's a very reasonable impulse as a parent. You want all the protection all the time for your kid. You're not allowing them to develop those coping skills that they can really build. So it basically teaches parents to do what we call empathize and encourage their kids rather than swoop in and protect them from all possible difficulties or adversities.
Are the parents in a separate single intervention thought? Is the idea that you would do the children in one and then the parents in another?
So the cool thing about Jenna's intervention is that it's just for parents. So there's no requirement that the kid be there at all or that they receive anything. And we took this approach based on research that's been coming out of the Yale Child Study Center recently, that if you compare exposure therapy, which is for kids to help them face their fears, to workshops for parents that teach parents how to encourage their kids to face their fears, they are equivalent in reducing anxiety disorders in kids. So there are multiple ways to make a difference, right? You can either focus on parents or focus on kids. And Jenna, through her program, Project Empower, which is freely available on our lab website for anybody to try, she figured out a way to make a difference for parents in a digital single session program.
And have you piloted this program in some urban centers or rural centers where they're not going to get a therapist?
Yes. So we've done one clinical trial on Project Empower with more than 300 parents from all across the country, actually. So pretty diverse representation across different regions, geographic regions, identities, socioeconomic statuses. And we were happily surprised to find that there weren't too many differences based on people's circumstances and their response to the intervention. Jenna, for her dissertation, is specifically now doing a study of Project Empower in parents facing financial insecurity. So folks who are at highest risk of not being able to interface with traditional systems of care. And I'm excited to see what her dissertation research finds, but that's to be determined still.
So you must be encouraged by the results so far.
Absolutely. I think every time we try to develop one of these new interventions and it works, I'm continuously surprised because I'm forever skeptical of most things. So I do find the replication to be really, really encouraging. Another example of one of our students' really amazing innovations, we received a grant from the Upswing Fund for Adolescent Mental Health to work with LGBTQ+ teens who face particular barriers to accessing mental health care, especially if they are in unaccepting homes. And we wanted to develop a single session intervention that would serve their needs specifically. Originally, we'd planned to just adapt existing ones for this population. But once we started talking to queer teens from across the country, we realized we really need to acknowledge the sort of context of oppression and discrimination that they're facing, not just focus on internal changes they can make. So one of our graduate students, Jenny Shen, really took a leadership role in building a program called Project Rise, which teaches teens who are sexual and gender minorities about minority stress, why the fact of having an oppressed identity in this world, in this political climate, makes coping a whole lot harder. It's not just you, right? It's this system that you're in that's really problematic, and it is unfair that you have to cope with it. Yeah. And there are still things you can do to help yourself and to get through. So we found that Project Rise, when delivered to LGBTQ+ teens in a randomized trial, significantly reduced internalized stigma and also reduced hopelessness and depression. So the students on our team are just doing incredible things, I think, to bring this to diverse populations and to address different needs.
Well, thank you very much for sharing this work. It's super exciting, Jessica.
It's wonderful. Yeah. Before you sign off, will you just let everybody know the full name of your lab? Because we have people that are watching this that maybe would want to kind of, join forces with you, or perhaps they want to get individual information. So, where can they reach you?
Absolutely. So I direct the Lab for Scalable Mental Health, schleiderlab.org, my last name. And we're located at Northwestern University. And we welcome partners from all sectors. I think that's the only path to making change here.
And also you have a book coming out, Little Treatments, Big Effects, How to Build Meaningful Moments That Can Transform Your Mental Health, which is coming out soon, right?
Yeah, the US release is on January 16th, although it's out on Kindle now.
Amazing. Thank you for this work. I mean, it's exciting. Yeah. Goodness knows there's a lot of people that need help, and to have these sort of new ways of thinking about intervention, it's just wonderful. And it really kind of changes the field, I hope, for you and for everyone.
I hope so too. Thank you.
Yeah, thank you, Jessica, very much.